Hello everyone, INI-CET 2026 conducted recently, and here we come with the pulmonology recall questions. And trust me, some of them are classic traps. Hello everyone, I'm Dr. Priya Sharma, consultant pulmonologist, and welcome to Breathackers, where we actually simplify pulmonology for the real exams. So if you are preparing for INI-CET NEET SS or even your MD, DNB or DM exams, this series is going to be a quick revision weapon. Before proceeding further, let me tell you these questions are reconstructed from recall only, and the options as well as the question may not exactly match the original exam. So the emphasis is only to identify the key concepts and clinical reasoning behind them. Just an overview that paper consisted of 80 questions, where 60% was pulmonology and 40% was medicine. Pulmonology questions we'll discuss in elaboration, and medicine focused on high core areas. Mostly question came from MI classification, thyroxine dosing, adrenal disorders. So let's start with the first question and see if you would have gotten it right under your exam pressure. So a 52-year-old female presented with sudden onset dyspnea and pleuritic chest pain for 6 hours. She is hemodynamically stable in terms of BP, heart rate, and SpO2. SpO2 is slightly 90% on room air. ECG is showing sinus tachycardia. Cardiac biomarkers revealed elevated troponin T and NT-proBNP. Echo showed right ventricular dilatation with hypokinesia. CTPA confirmed the diagnosis of pulmonary embolism. So what is the most appropriate risk stratification of this? So they have given the option based on the previous classification, although A to E grading has come in the latest guidelines, but the question came on the basis of the previous classification. And since here troponin T, NT-proBNP, the biomarkers were raised, echo showed positive signs. So this came under the category of acute intermediate risk pulmonary embolism. So B is the right option here. Coming to the next question, which of the following is the lactose fermenting bacteria? Pseudomonas aeruginosa, Klebsiella pneumoniae, Salmonella typhi, and Shigella dysentery. So lactose fermenters include Klebsiella pneumoniae and E. coli, and they are called lactose fermenters because they'll show pink colonies on McConkie agar. Then you have non-lactose fermenters, which shows colorless colonies, and the example of this are Pseudomonas, Salmonella, and Shigella. So basic clue to remember is mucoid plus pink is classic because Klebsiella has a thick capsule. Coming to the next question, third question, a 64-year-old male chronic smoker, known case of COPD, worsening exertional dyspnea, BMI 19, FEV 142% of the predicted MMRC grade 3, and 6-minute walk distance 220 meters. So they wanted you to calculate the board index scoring. For this patient, it will be 7, where B stands for BMI. Less than equal to 21 is 1 point. O stands for obstruction, FEV1 percentage predicted, where they further classify, since here it comes in the category of 36 to 49%, it gives us 2 more points. D stands for dyspnea, MMRC grade 3, again 2 more points. And last is 6-minute walk distance, exercise tolerance, 150 to 250 meters there. And so we add 2 points more. So 1 plus 2 plus 2 plus 2, 7 is the answer. So coming to the next question, number 4, a 35-year-old male presented with acute onset left-sided chest pain as well as breathlessness. Chest X-ray showed a left side pneumothorax. ICD was inserted. Chest X-ray showed a near complete resolution of pneumothorax, and then they got a CT done. The CT chest image, which is given here, might not be the same or matching the exam. Also, the options which are given here may not exactly be the same. This is based on recall only. So, but the main key aim of this question is that you should know the management principles of pneumothorax. But if anyone remembers this question more accurately, feel free to share in the comments. So coming back to the question, there is no history of trauma. And so they asked, what is the next best step in the management? So A is we'll observe with ICD removal once lung fully expands. Second, we'll do a chemical fluorodesis only if the patient has a high risk profession like being a pilot or a driver. Third, we start treatment on PCP pneumonia. And fourth, we'll screen for HIV infection in all such patients. So for me, I think A was the correct answer because I think this is a question of primary spontaneous pneumothorax. There is a young male patient has some spical blebs and cyst. And after the first episode with resolution, normally what we do is just observation. Of course, the definitive intervention pleurodesis is needed if patient has a high risk profession or if there is a recurrent pneumothorax. Also, the contralateral cyst in this CT hints at the underlying bleb disease, and it does not mandate an immediate intervention unless the patient is at high risk profession or there is a recurrence, which is not mentioned here. And all this PCP and HIV infection, they were actually the distractors for this question. Coming to the next question. So 58-year-old male with a suspected malignant pleural effusion, planned for ultrasound guided pleural tap. A curvilinear probe is routinely used for localization. However, the clinician who was doing the tap, he changed it to linear probe during the examination. So what is the primary indication of using a linear probe? Does it provide a wider field of vision for larger pleural effusion? Does it provide a better visualization of deep pleural fluid collection? Or it provides a superior assessment of pleural surface abnormalities such as nodularity and thickening, or it improves the detection of minimal pleural effusion in dependent areas? So correct answer is C. Superior assessment of pleural surface abnormalities such as nodularity and thickening. So this could be better visualized with the linear. So coming to question number 6, a 48-year-old female presented with gradual dyspnea on exertion. There is no history of left heart disease. RHC revealed mean PAP of 35, which is of course elevated because the normal value is 20. Pulmonary capillary wedge pressure is 10, which is of course 15 less than equal to 15. We consider it as precapillary pulmonary hypertension, and pulmonary vascular resistance is elevated. So which of the following best describe the type of pulmonary hypertension? So they actually wanted to know whether it is precapillary, postcapillary, mixed or isolated postcapillary. So answer for this question is precapillary pulmonary hypertension, because in this MPAP is raised, PCWP is usually less than equal to 15 and PVR is usually elevated. So answer is A. So coming to the next question, 7, a 55-year-old male with long-standing CLD and portal hypertension presented with dyspnea on exertion. On evaluation, you got a ABG done, which showed hypoxemia and a raised A-A gradient. Hemodynamic assessment is being done to differentiate pulmonary vascular complication, which is hepatopulmonary syndrome and portopulmonary hypertension associated with liver disease. Now, which of the following finding would make you think portopulmonary hypertension least likely? And the option they gave was a raised MPAP with a normal PCWP, elevated total vascular resistance, normal pulmonary capillary wedge pressure, or a raised alveolar arterial oxygen gradient. So answer for this question is increased alveolar arterial oxygen gradient. Why so? Because portopulmonary hypertension is the criteria for diagnosing portopulmonary hypertension is raised MPAP. PCWP is usually normal, and pulmonary vascular resistance or total vascular resistance is usually high. Whereas in hepatopulmonary syndrome, this A- gradient will be high and there will be hypoxemia due to intrapulmonary vasodilation. So answer will be A- gradient, which signifies it to be hepatopulmonary and not portopulmonary hypertension. Coming to question number 8, a patient with unexplained dyspnea has a normal spirometry, normal lung volumes. Now, which finding would make you most strongly suggest to explore a pulmonary vascular pathology? Is it normal spirometry? Is it normal TLC? Is it decreased DLCO, or it is a increased residual volume? So answer for this is decreased DLCO, of course, will make you think towards pulmonary vascular pathology. Coming to the next question, question number 9. Which of the following macrolide dosing regimen is not appropriate for the treatment of community-acquired pneumonia? So options given were azithromycin 500 mg stat followed by 250 mg OD, Clarithrol extended release formulation OD, and Clarithrol 500 mg BD or azithro 250 mg BD. So of course, everyone knows the answer is azithro 250 mg BD. This is the wrong answer because this dosing of macrolide is not indicated for community-acquired pneumonia. Coming to the next question, question number 10, which was on brensocatib. So the options given were it is used in the treatment of COPD. It acts by inhibiting DPP1, thus by reducing neutrophil elastase activity. Fourth, it can cause dermatological side effect like hyperkeratosis. Fifth, it reduces neutrophil serine protease activation by blocking their maturation. So this was the wrong answer. It is used in the treatment of COPD. As we know, it is being used in bronchiectasis, FDA approved in bronchiectasis, and reduces the exacerbation. There is a video uploaded on the channel on brensocatib in detail. Here is the link to go through. So coming to the next question, this is one of the controversial question. So a 24-year-old male with a history of recurrent hemoptysis for last 13 years now presented with daily hemoptysis for past 2 weeks. The patient has undergone bronchial artery embolization. Now, which of the investigation is least likely to affect your outcome at this point of time? So I don't know if this question is absolutely correct or the options are absolutely correct. And everyone will have a different opinion and different answer for this question. But I'll explain my part of answer. So for me, A will be the right answer because the patient is chronic hemoptysis and BA has already been done. So now our focus should be on localizing the source of hemoptysis, or if there is any infection, to control that infection. Just to find out what infection it is, we need to have sputum for NTM and we need to have sputum for bacterial culture. And airway evaluation should be done to rule out site of any active bleeding. Serum IgE for AVPA is least urgent or relevant at this point of acute ongoing hemoptysis setting. So anybody having a different opinion, different answer, different explanation for this question, or anyone knows this question and options better, can of course comment in the comment section. Coming to the next question, 12, 68-year-old male, known case of ischemic cardiomyopathy and COPD presented in emergency with acute breathlessness. Lung ultrasound shown here shows multiple vertical lines bilaterally in all the lung fields. So this is one of the lung fields and there are more than 2 vertical or big lines. So this is a clear case of pulmonary edema. So B is the answer for this. Coming to the next question, 36-year-old male with chronic cough undergoes bronchoscopy. BAL showed AFB stain positivity, CB-NAT negative. So of course this is NTM here. Now the cultures started showing growth positivity at 5th day. So now they are talking about rapid growing mycobacterium. And among all these 4 options, abscesses is the one which is rapid grower. So A is the answer here. Coming to the question number 14 on rifapentine, a higher area under the curve is most closely associated with which of the following implication? Options were low dose can be given irrespective of weight bands, prolonged bactericidal effect allowing intermittent dosing, reduced risk of drug interaction due to lower peak levels, and minimal post-antibiotic effect compared to rifampicin. So correct answer here is B, prolonged bactericidal effect, allowing intermittent dosing. Rifapentine, as we know, we do intermittent regimens. Maybe it's used in weekly terms because it has a very long T half and it has a higher area under the curve. So you will have a prolonged exposure. Also, the area under the curve driven killing also tells that there is a sustained bactericidal activity over a long time. So B is the answer here. Coming to the next question. So MGIT 960 system, they ask about the level which correspond to the middle growth based liquid culture detection system. You just have to learn it. This is level 11. Coming to ARDS, patient with moderate to severe ARDS, which of the following interventions showed most consistent mortality benefit? And among all these four options, of course, low tidal volume and high peak based on ARDS net protocol. So A is the answer. HFOV has a weak indication. Early initiation of glucocorticoid, again weak indication, and routine use of inhaled NO. I don't think it has any evidence of mortality benefit in ARDS. Which of the following is not a risk factor for OSA in females? So OSA is more common in postmenopausal status rather than in young age. So A is the correct answer because this is not a risk factor for OSA in females. So coming to the next question, question number 18, all of the following antiplatelet agents should be stopped 5 days before an endobronchial biopsy planned, except, so all the three options given initially, A, B, C, ticagrelor or prasugrel, clopidogrel, they need to be stopped 5 days before an endobronchial biopsy is planned. And D is the answer here. So this is basically all the NOACs, they need to be stopped 24 to 48 hours prior to any biopsy for our bronchoscopic procedures. Coming to the next question, which of the following organism is most commonly associated with GPA? So options given: Staph aureus, Streptococcus pyogenes, Malassezia purpura, Pseudomonas aeruginosa. And of course, we know chronic nasal carriage of Staph aureus is linked with the increased disease activity and high relapse rates in GPA. And that is why we give Septran in patients who have upper airway or nasal involvement in cases of GPA. So, of course, the answer for this remains a Staph aureus. Coming to the next question, which of the following is not included in the Lent score, which is used for the prognostication of malignant pleural effusion? So, answer for this is pleural fluid glucose, and the Lent you should know actually, where L stands for LDH, E for ECOG performance status, N for NLR or neutrophil to lymphocyte ratio, and T stands for tumor type. Coming to the next question, which of the following is not a prerequisite before performing MSLT? A, discontinuation of antidepressant for at least 2 weeks, maintaining a sleep diary prior to the test, avoidance of any stimulants before the test, and discontinuation of CPAP therapy before the test. So discontinuation of CPAP therapy before the test is actually not needed, and rest of the three are actually needed. So this is the answer. Now, a patient with a septic shock remains hypotensive despite initial adequate fluid resuscitation. So in this one line, they tell you that they have given the adequate fluid resuscitation according to the septic shock bundle. Now, which of the following is the most appropriate next step in management? So according to me, B and C both are the right answer, but I think C will be the right answer for me, but then I don't know if B is also a right answer. So continue fluid resuscitation until CVP reaches 10 is wrong. Guide further fluid therapy using the dynamic parameters rather than using static CVP monitoring is of course right. And then because it is not improving with the adequate fluid resuscitation, so you have to use noradrenaline. Of course, this is also right. And rely on CVP alone to guide resuscitation is wrong. So definitely A and D are wrong, but among B and C, I am still confused which one to choose. But if I have to choose one, I think I'll choose the C. Coming to the next, 52-year-old male presented with progressive dyspnea and dry cough. On examination, patient has clubbing, bilateral basal crackles, HRCT showed reticular opacities with traction bronchiectasis, BAL reveal lymphocytosis. So this is the main point, lymphocytosis. So they have described a UIP character, and if you look at the differential diagnosis of UIP, HP is also one of the differential of UIP, and there is lymphocytosis in HP, and there is neutrophilia in cases of IPF. So here the answer will be HP rather than UIP. UIP, of course, is a pattern, but the diagnosis will be HP here. Coming to the next question, a patient with MDR-resistant TB has failed with the shorter MDR-TB regimen. Which is the next best treatment option? I think everyone knows this. If a patient has failed on a shorter MDR-TB regimen, so best option among all these four will be to start on oral individualized regimen based on drug susceptibility testing. Coming to the next question. So a 45-year-old female chronic smoker, dyspnea, history of spontaneous pneumothorax, HRCT is shown below. If you could see, I mean, what is the most likely diagnosis? The only thing which they have given is female, which is somewhat controversial. But ऐसा नहीं है. PLCH is also common in females also. So I think LCH still remains the answer for this, as the lung parenchyma between the cyst also shows some nodules here. So I think LCH remains the answer here, even if it is a female. But since she's a smoker, so of course she could have this. Coming to the next question. 42-year-old female, systemic sclerosis, progressive dyspnea for last 6 months, PFT short FVC of 70%, no evidence of any other organ involvement. What is the next best step in management? So, nintedanib, I think they have given FVC 70%, so that makes nintedanib out of the criteria. Giving steroids in systemic sclerosis, of course, predisposes to a sclerodermal renal crisis. So again, this is out. Coming to the third, I think this is the right answer. And repeat evaluation after 6 months with counseling, since patient is symptomatic at this point of time, progressive dyspnea over 6 months. So I think we can't leave the patient and we have to start the patient on mycophenolate mofetil. Coming to the next straightway question, 38-year-old female presented with recurrent hemopsis, FOB revealed an endobronchial growth. Biopsy was performed and histopathology showed synoptophysin positivity, chromogranin positivity. Ki-67 was low and there was no necrosis. What is the most likely diagnosis? Of course, typical carcinoid. So in typical carcinoids, these synaptophysin, chromogranin, these neuroendocrine markers are usually positive, and there will be minimal mitosis, no necrosis, and low Ki-67. Whereas in cases of atypical carcinoid, there will be high Ki-67, there will be necrosis and aggressive features. So of course, the answer for this remains typical carcinoid tumor. Coming to the next. A patient 2 months after the lung transplantation presented with dyspnea. HRCT shown here showed bilateral GGO. What is the most likely diagnosis? So basically the timeline matters here, which is 2 months after the lung transplantation. So initially in the 1 to 6 months, opportunistic infection like CMV, which presents like this with GGO, diffuse GGO. Of course, that is the most common thing. Aspergillosis will have nodules and halo signs, which is not here. Of course, rejection can have GGO, but then GGO like this are more classic for CMV, and also the timeline is more classic for CMV. So CMV is the right answer here. Coming to the next question, a patient present with acute breathlessness, point of care POCUS showed this ultrasound which is given here, what is the most appropriate interpretation? So here they have shown a C4 sign on M mode, which says pneumothorax is ruled out. So pneumothorax present, no. Pneumothorax ruled out, yes. Possible pneumothorax, further evaluation, no. If you could see a lung point, lung sliding sign, there is no pneumothorax, of course. So B is the answer here. Coming to the last question, a patient with ARDS is on mechanical ventilation. These parameters are given: PF ratio of 120, FiO2 of 80, PEEP of 10. What is the next best step in the management? So I'm not sure of this because some would say that you can start on low tidal volume ventilation, but I think patient is already on low tidal volume ventilation if we consider that. So for me, it will be to initiate prone ventilation. FOV, of course, has no role. FiO2 you can increase, but then at this point of time, I think prone ventilation matters. But whatever the answer or question or option is, you just make sure that you read the ARDS protocol. So that was all about the INI-CET 2026 pulmonology review from my side. If you like this review, please share and subscribe. Thank you.